understand what truly goes into this decision. Because we don't want to see misunderstandings or say, well, we've decided this is a maintenance patient. We have to develop those criteria and really think about how we defend the needs of that patient. A little litmus test I like to use is very often therapists, nurses, home health agencies will say to me, are you talking about skilled care or maintenance? The use of the word or in between those concepts I think is very indicative of some of our issues. We've kind of believed that maintenance was less skilled in some capacity, that it was just maintenance. I hear that a lot. Why can't therapy assistants do this? This is just maintenance. Or my personal favorite still remains the therapist who said, I understand maintenance. It's when I stop trying. Oh, we're getting some significant echo, Megan. Are we okay? Oh. I want to make sure everyone listening. Care is on one island and maintenance on another is also categorically untrue. We need to look at our provision of services, and this is applicable to nursing as well, that the skill is what the clinician knows. It's what the therapist is trained to do. It's what they've acquired through their training. It is not defined by the problems of the patient. The problems of the patient need to be identified, but they're the patient's problems. That's not the skill. The skill is what we bring to the situation. The issue of whether or not we're talking restorative or maintenance is based on the path we choose to take. And in all situations, we have to be able to show that that decision made sense, that it was reasonable. It's not reasonable to assume that maintenance therapy means 3 times a week for the rest of the patient's lifespan. That isn't reasonable. That's not what the benefit covers. So we need to really think about this carefully because we don't want to open the floodgates and have this be, oh, wow, so I can keep that patient who cries every time I talk about discharge, I'll just put them over on maintenance. As leaders, you cannot risk that because we always have to be able to defend that the decision required the skills of a therapist, was reasonable to do in this situation, and was absolutely necessary. It was essential. It was indispensable to this patient that that happened. I have to be able to show that no matter what course of care I take. Because the bottom line, if what I do could be done by somebody else, then it doesn't stand up as skilled, distinct therapy services. We have to really think about the complexity. And a lot of this with maintenance therapy is not actually in the performance of exercises or activities with the patients. It's the skill required to oversee that activity. Not a reminder, not a cheerleader, but to determine if those exercises I gave that frail 90-year-old man with CHF and COPD, are those really the most efficient and safe ones for them to be carrying? Just having them demonstrate them back to me or verbalize understanding is only one piece of this. I have to determine if what I gave them to do is really a good idea. And that takes revisiting. That takes looking at this and saying, are we achieving the stability of function we were going after? Or, because the patient's medical status is going up and down, maybe when they have a bad week, they don't do any of these activities. Well, okay, how do we scale it for this patient depending if he has a good day or bad day? You start to see the amount of skill involved, but many therapists are still very stuck in, I give a home program or I make a recommendation. As soon as the patient can return, demonstrate, or verbalize it, then I can't go back anymore. When in reality, yes, we can. The issue is how we do it and how do we document it. Myth number 4, up in the northeast part of the country, probably takes on a whole new level of awareness specific to the JIMO case, because this whole removal of the improvement standard is partially why the spotlight went back on maintenance therapy in terms of, are we actually doing this? Now, it came and went fairly quickly from a media attention standpoint. Yes, this happened. Patient advocacy groups got on board, tried to educate the beneficiaries about it, and some of you may have encountered the patient or the family who says, I've read about this, you can never discharge me. Well, we need to be extremely clear that the JIMO case did not actually change the benefit. It caused Medicare to have to clarify some language, but the idea of maintenance therapy has been in our benefit manual for more than 20 years. The issue comes into play about if we're providing it, are we using the correct G codes? And as we said at the very beginning, if I have chosen to not deal with those G codes, to not present them and not use them, but I have therapists, back to our clinical example, who are doing these preventative focused cases, I need to make sure that not only do we understand the clinical reality, but the billing reality. Because if we've never ever billed for it, when now we may realize we've done some of it, we need to reconcile how we're going to move forward with this. And in our webinars, we talk about the G codes and help the therapists understand that they're not paid differently. There's no different rate for those from Medicare, that they count the same as every other visit, that a PT can choose a maintenance course while OT chooses a restorative course on the same patient. We don't all have to have a huddle and decide. But to get that clinical decision-making there so that when you bill this, you can bill with confidence, and that you're able to monitor its use going forward. So if all of a sudden you start noticing what looks like a maintenance free-for-all, you can put a stop to it and say, wait a second, let's make sure that we're all on the same page about the qualifying criteria, as well as what are those 3 specific coverage criteria for therapy and home health. As a therapist, I will tell you, many of my peers have never read this. We've maybe heard about it in orientation or maybe had it talked about, periodically as some sort of concept, but it appears to be, in my interactions, not very many of them have ever read it. So when we do this in the webinar, we talk very specifically about these 3 coverage criteria. That the one on the left, the restorative box, is where we're very comfortable. Box 2 and box 3, so essentially 2/3 of our coverage criteria, are specific to the word maintenance. And for many folks, that's kind of eye-opening. They didn't know this. They thought this is because of the Jimmo thing or this is a new thing. It's truly not, which raises a lot of questions. If it's not new, how come we were so afraid to touch it? Well, we probably all heard those stories of people that kept people forever or did a ton of visits or got in trouble on audits or those kinds of things, and it's made many of us very phobic about this. So we have to get a good regulatory grounding, which is what the first session spends a considerable amount of time on, being very clear not only of what these coverage criteria are, but what is skill, what is reasonable, what is necessary. So we're approaching this within the boundaries of the benefit. When we talk about skill, we know that there's been a lot of discussion since 2011 around the use of tests and measures with therapy. The regulatory language really pushes on objective measure. But what's been interesting, that Dee and I are finding that many therapists, okay, I have to do a test, I have to do a measure, but why would I do that for a patient who I don't think is going to improve? My goals for these patients are to stabilize function, to prevent decline, to maintain their ability. So why would I use any measure if I'm not going to use it to show improvement? Well, it's a very interesting question because there really is no difference in how we evaluate a patient. The decision about am I going to take a maintenance focus or am I going to take a restorative focus, or do I see myself starting out restorative and probably several weeks into it, potentially switching to maintenance, the evaluation is identical. The use of tests and measures is very important in these situations because it is much better to have a measure and then over a period of time remeasure to validate that they've stabilized than just saying they've stabilized. But it's been interesting to see therapists a little bit confused about this. So we talk about the importance of a thorough assessment, and we provide a decision tree like this to say, okay, how do I choose a course? It's not just, is the patient going to return to a prior level of function, or are they at an optimal level, but do they need the skills of a therapist to get to those points or to stay at those points. So we found in our feedback from our different groups that they really like that decision tree to kind of guide the conversation as to where should we end up. Because you can see 2 of those boxes end up at no therapy. If they don't need a therapist to return to their prior level of function, or they don't really need therapy to keep their functioning where it is, then we still don't provide it. It's not necessary. It's not reasonable. So we really try to illustrate that the assessment is the assessment. You make the decision about the course of care after that. Our sixth myth is one that I kind of chuckle at, because I get told, well, maintenance patients don't have goals. I mean, how can you have goals? They're not going to get better. One of the things I'm learning over and over in the last probably 18 months is I believe that the whole GMO and there's no improvement standard, and isn't this great from a coverage criteria standpoint and to decrease denials. But I think it's exposed how addicted to improvement therapists truly are, and how many organizations are so used to seeing us increase gait distances, increase repetitions, increase this activity, decrease the level of assistance, that you're not necessarily comfortable thinking about documentation that doesn't look like that. How am I going to know if this is still skilled? What if they just keep going and the measures never change? Isn't that going to put us at risk? The issue has a lot to do with how do we establish goals. Clearly, we have to have goals for maintenance patients, but we really have to think about what goes into them. Are we clear about who it applies to? Do we see it? And do we have a time frame on it? Do we really think this is going to be accomplished in 2 weeks, 2 months? What are we really thinking about in terms of a time frame? Knowing that many parts of a goal can be adjusted over the course of care based on the presentation of the patient. I think many of our therapy goals have become very vague and generic so that we don't have to update them. The thing is, updating goals really does show, in many cases, a higher skill level because you're adjusting your plan based on the presentation of the patient. So with maintenance patients, we find many clinicians kind of struggle with what does a goal look like, and what we don't want is a bunch of goals that now just say maintain ambulation, maintain strength, maintain range of, I mean, if we don't have measures of relevance, that could be a recipe for disaster. This question, I think, is a very interesting one, and this one was posed directly to CMS more than a year ago. And I think the interesting piece about the functional reassessment, and even the fact that anybody asked this, gives us some insight. Because if I think that therapy is all about progress and improvement, and I'm addicted to that, and everybody's on my same page about this is what therapy is supposed to look like, and I think that the functional reassessment is just about showing my progress, well, if I have a patient and he's not going to show progress, then why do I have to do the functional reassessment? The response clearly says from Medicare, yes, they are expected. And although the 1319 is gone, 30-day is still in play. So yes, they can become very relevant in maintenance cases. It is important to understand what actually goes into that, because if my patient is stabilizing, what am I showing on this functional reassessment? So we spend some time really talking about demonstration of skill and why we're going to be able to say additional therapy is warranted. But from a leadership level, we say, okay, I kind of got the myth piece, but why would I need to expose them to this? Why do we need to have, yes, I know patients could benefit from this, and that's an important piece, but what are some of the operational issues? Well, one of them is, do your clinicians really understand how to execute maintenance? And again, there's quite a bit riding on your therapist being competent in doing this. But I would argue that your nurses benefit from the same education. If nothing else, I would guarantee every one of them at some point in their home health career saw a patient that had functional deficits, made a referral to therapy, got only an evaluation out of it, and a talking to from the therapist about that was not the right patient to send. A lot of damage has been done in that model that we now have nurses who look at that 90-year-old with COPD and don't even think about ordering therapy because the message they've heard from us is, unless they're fixable, we can't see them. So we want to undo that piece as well. So the information in the hands of the nurse in terms of facilitating referrals, coordinating those discharges, helping to coordinate that overall plan of care is an important piece of this conversation. Looking at staffing implications. When we think about the more restorative model, there are some things that need to stand out to you. If you're not sure still, do I really need to go to this training? Take a look at your cases that have only had an eval only. Those patients that keep coming back for therapy, that they come back over and over, or they get maybe 1 or 2 visits and are said no rehab potential. Just take a look at the documentation of those. Very often they contain instruction, recommendations, equipment ideas, home modifications, and no follow-up. This is not because your therapists don't want to do it. Many of us truly have believed that we couldn't. So we're trying to give them all these tips and suggestions in this one visit or maybe a second visit because we don't think we're allowed to come back. Rehab potential does not mean improvement. Rehab potential has never meant that. It means, can they benefit from the skills of a therapist? So take a look at current practice and utilization in your agency and think about when we start talking about implementing maintenance, these are notoriously not your patients that are on the high end. Daily therapy, high frequency, high intensity therapy is more the restorative model. Maintenance tends to get into once a week or every other week, the inclusion of PRN visits as issues arise. That feels very different to many home health therapists. We have very much been in a 2-time-a-week or 3-time-a-week for X number of week model. Also for reviewers, that's what you're used to seeing from us. How do we better manage our resources with some patients that don't need a therapist to come and do these exercises with them, but to monitor the plan? That is a much better plan to see that patient maybe twice a month than it is to turn around and say, well, I'm going to keep them 3 times a week because I'm a nice person. Because if I am billing under the restorative code and I don't show restoration, I do run a risk of denial. That is why it's so important to properly identify and utilize maintenance therapy. Ongoing monitoring. You know, when we look at these, we also look for opportunities in relation to, have we had some challenges with rehospitalizations? Those patients where we improved them to a point and then left and they slid right back down the hill and came back, or slid down the hill, went to the hospital and came back. We struggle with this and say there's got to be a better way to manage them. Maintenance therapy is an integral part of that. It doesn't fix everything. But what we believe is many therapists are very apprehensive and unsure, and some of them, a few of them, are belligerent that they will not do maintenance. But from a patient management perspective, from disease management, looking at the numbers increasing of our frail elderly, multiple comorbidities, chronic disease management, we have to think about how do we include therapies appropriately when they're contributing to issues more than just numbers of visits. What is this doing for outcomes, rehospitalization rates, prevention of them declining to the point where they have to go to a skilled nursing facility? There's different ways we can be utilized here. And we also have to understand, and we're very clear in all 3 parts, documentation has to be on point. That we've already seen some evidence of people saying, excuse me, I do maintenance. Can't you tell? I put the word maintenance in a whole bunch of notes. Okay, just putting the word in there is not going to fix this. We have to be able to show skill. And I can confidently tell you that although the 3 sessions are focused on maintenance therapy, the discussion of what is skill, what should be in goals, what is the focus of care, has had a very nice, I expected it, many attendees do not, it has actually helped to improve documentation overall, a sore spot for many of us, because we go round and round with all of our clinicians about what they need to document, and they just say, why don't you just tell me what you want to see, and I'll put that down instead. Understanding what my skill is in a maintenance situation, to really acknowledge that complexity and oversight, kicks up my restorative documentation as well. Because the issue in both cases is, can you show why a therapist needed to be there? So not only do we have the ability to discuss this in terms of the important issues of maintenance, but we also have a inadvertent, unintentional maybe, but it worked out well, connection back to documentation risk overall in terms of showing exactly why you did what you did. Because at the end of the day, as therapists, we have to be able to show that what we did took our skill, it was reasonable to do so, and it was necessary. This applies to every patient we come in contact with. So a lot of these myths we started off with, or these misunderstandings about maintenance, tend to stand in the way of good conversation about appropriate use of this piece of the benefit. So that's what, kind of drove this creation of a 3-part webinar series. And sometimes we find that even after that, individual organizations are like, we're still confused. We look at things that we can do to assist there as well, because we're confident and believe that, let me just boil it down to this. Back to my room of 50. If I asked a room full of 50 people who did maintenance and 2 hands went up, and then we talked about it clinically, and I said, how many of you done that? And it's still those same 2 hands, I would not be as worried. Yes, we would still need to educate. We would still need to look at this from a patient perspective and documentation and everything we talked about today. But when it's 2 hands when I ask maintenance and 49 hands when we go clinical, that is a huge disconnect. And that has not happened to me just once, not just twice, at least a dozen times in the last 6 months. That big disconnect tells me we have got to get our arms around this. Because if I have therapists out providing what is truly maintenance, but it's being coded as restorative, and there's no restoration seen, that can contribute to my denial risk regardless of the GMO decision. And there is a high level of attention on not only CMS for clarifying their regulations, but on all aspects of the post-acute continuum. Are you providing this piece of the benefit or not? The GMO put light on it. Are we actually using it? So when you think about whether or not you should attend, even if you choose not to, take a moment with your staff and just ask them if we provide it. It's very interesting to have that conversation, or to ask nurses and therapists what they know about maintenance therapy. I did that with one organization. The nurse emailed me a very good description of what maintenance actually is. The therapist emailed me and said maintenance is not skilled and not covered in any setting covered by the Medicare benefit. So it's like, wow, you talk about a huge disconnect. That is very common, though. And so that's really our intent with this series. So we hope that you'll be able to join us for that adventure. There's no worries about what if I can't get to all 3, or gosh, those dates don't really work. We're recording those sessions because we know that not all of your staff will be able to get in one place at one time, or things come up, or blizzards or rainstorms, or all kinds of things can mess this up. So we want to provide that recorded version as well for reinforcement and consistency in messaging, because ultimately the implementation of maintenance ends up being more about cultural change and a mindset change than it actually is about the provision of therapy. And that takes a little more effort than just let's look at the manual and let's just go start doing it next week. That kind of plan tends to be quite risky. So Megan, do we have any questions? I know people might need to go. We said this was at half an hour, so you have my email address as well as that of my business partner, Dee Cornetti. If you have specific questions you want to just ask us about attending this or anything else, you have those available to you. But we can take a few moments, Megan, if anything's come in during the discussion.
Thank you, Cindy. Currently, we don't have any. Just so if anyone has any questions, we'll just wait about a minute or so you can get those in to us. But again, if you have any questions, feel free to email Cindy, or if you have any questions about how the webinar series works and everything, you can email me as well. I'm the one who's been emailing you all the information about the conference call and everything. So yeah, it looks like we don't really have any calls. Again, if any of you, I know some of you came in late. I do have the webinar recorded. There was some technical difficulties in the very beginning, so just a few minutes of it is cut off. But besides that, the rest of it's recorded, and I'll be sure to send it out to you. Just let me know if you want it yourself. Thank you again, Cindy, for doing this call for us. We look forward to working with you for the series.
Oh, and we very much are excited to work with you as well.
All right, great. Thank you all, and have a good rest of your day. Good luck with the cleanup of the storm. So, all right. Goodbye.